I am super excited and honored to have Dr. Reva Barewal here with us this evening to present Beyond the Bolus, Redefining the Oral Phase as a Neural Driver. If you have questions for Dr. Barewal throughout this presentation, feel free to put them in the chat or the Q&A, and we will monitor those as we go, and we'll have a Q&A session at the end. So with that, I'm going to hand over the floor to Dr. Barewal.
Thank you, Brooke. Thank you for the invite. I am going to share my screen. Are you seeing full screen?
Yes, it looks great.
Perfect. Okay, well, good evening, everyone. I think it's evening everywhere in the country right now. So I am in Portland, Oregon. I am a prosthodontist, and my background is such that it's taken me on a journey to dysphagia science, food science, culinary arts, and clinical evidence. And so very excited to talk about this subject. And without further ado, let's just jump right in. Full disclosure, I have a company. It's called Savory's Therapeutic Foods, and it is a functional texture company. Really is a foundation for my knowledge base in the field of texture modified diets. Okay, so here we go. So I think in this 1 hour, it's going to be kind of a rapid fire of different chunks of subject matter. So to begin with, I'm going to orient us to the question, basically, what is happening with our patients when we put them on a texture modified diet? You're following ITSE well, but intake is still low. There's low hydration, low engagement. And so my question is, what specific testable adjustments in the oral phase can help us move the needle without over-promising outcomes? So I'm going to define a term today called functional textures and how they can alter oral behavior, emotional behavior, and swallow behavior in a positive way, yet do so at the recommended ITSE texture level. So the question is, are all functional textures transitional foods? And the answer is yes, but the reverse isn't true. So not all transitional foods are functional textures. And we're going to go over that. We're also going to go over a new term that you might not have heard. It's called tribology, but it's really important for you to know that because it defines food texture in a very different way than ITSE. And it's important to understand. And lastly, we're going to talk about a structure that you can use for including functional textures for your patients and the indications according to a framework. So we've all seen this, again, those trays that meet those ITSE requirements, the airways protected, and yet the patients are not eating or drinking enough, and their motivation is fading. So what do we do? So we can give them more puree. We can increase calories and protein with oral nutritional supplements. We can use verbal cues to encourage them. You can even alter how you're giving the supplements in the form of Medipass and so much more. But they still eat fewer calories than needed for recovery and health. And this increases risks for malnutrition, delayed healing, poor outcomes, including satisfaction and quality of life. It's been reported over and over again. In hospitals, dysphagia patients typically consume 20 to 40% fewer calories than in non-dysphagia patients, and malnutrition affects 45 to 62% of dysphagia patients. Adherence to having oral nutritional supplements is at about 67%. So your focus is to safely advance skill strength, and endurance enough to progress their diets ahead of the weight loss, malnutrition and dehydration, peg tubes, and more. And I'm going to share how adding functional textures can alter the nutritional outcome for your patients through a really different way than you're used to thinking about food. So let's step back and go through Logman's stages of the swallow, but focus on the oral and pharyngeal phase. The oral phase is usually presented as bolus containment and propulsion, lip seal, tongue pressure against the palate, coordinated jaw movement, and cheek movement. But if we stop there, we miss a deeper physiology. What is really happening during these stages between the oral phase and the pharyngeal phase? It is continuous sensory motor traffic. Mechanoreceptors, chemoreceptors, thermoreceptors in the oral cavity, tongue, and pharynx. They're sending rich afferent input to the brainstem and to the brain. This is why um, like authors like Jean, Miller, and Steele have proposed that the oral and pharyngeal phases should be thought of together as the oropharyngeal phase. And I want to say the boundaries we draw mechanically don't exist neurally, but they integrate in the excitability, timing, and safety of the pharyngeal swallow. But I don't want to be remiss and not mention the pre-oral phase. It's really important from a sensory perspective, and our talk today is largely about the neurosensory mechanism with food. Even before food enters the mouth, we all know the brain is preparing to chew, right? Before anything touches the tongue or the teeth or the lips, anticipation lights up the insula, prefrontal, and motor regions. These visual cues, the smell cue, and context all activate cortical networks. Eisner and Schoen have shown us that anticipation itself is part of swallowing behavior. This is where identifying food as food comes in. When a patient sees something familiar, especially food with the form of a solid or something crunchy, the brain recruits motor plans for mastication before the first bite. That anticipatory activity increases salivation, sets an attentional readiness, and primes descending input to the swallow centers in the brainstem. So today we're going to focus on the oral phase, and I call it the gateway to the swallow. But I'm not going to take that mechanistic approach of bolus prep and transport, but instead focus on the sensory and motor systems and how they start priming the pharyngeal swallow. So in looking at this diagram, we can see the oral phase runs its own network. The moment food enters the mouth, touch, pressure, taste, and temperature are carried, all those inputs are carried by the cranial nerves 5, 7, 9, and 10. Now, where they go is they stream into the nucleus tractus solitarius within this formation called the intermediate reticular formation. And this is happening in the brainstem. And from there, signals circulate within the nucleus ambiguus and the swallowing central pattern generator, or CPG. And you get this return of motor output through cranial nerve 5, 7, 9, 10, and 12. And when you're chewing food, this loop is running continuously. It's keeping the system warm. It's not triggering a swallow, but you're basically holding this network in the brainstem at readiness until bolus cohesion and lubrication crosses the threshold to the swallow. And so layered on top of this is what's happening in the cortex or the brain. And it's really this intermittent influence. The insula, the operculum, attention reward circuits, these are modulating circuits. They're modulating timing, force, and engagement. So the oral phase isn't just a waiting room per se, where we have a mechanistic idea of what's happening in the room there. It's a live conversation. It's a continuous brainstem loop, maintaining that readiness with episodic cortical input, fine-tuning that response. So how does this sensory input affect our emotions? So we know that this all of the sensory, the taste, the smell, and temperature, they feed into an emotional response. But it's not in the brainstem. This is ascending in cortical and limbic centers, engaging the attention, motivation, and reward. That's why food that is familiar and flavorful doesn't just prepare the swallow, it re-engages a patient emotionally. Biting, chewing, tasting, smelling are essentially afferent signals that not only prime the swallow, but also reconnect eating to pleasure and identity. So when we activate the oral phase sensory system fully, we're not only improving swallow readiness, we're giving patients back a piece of themselves. So my career focus as a prosthodontist was really, if we're talking cranial nerves, it was on the trigeminal nerve, cranial nerve 5. I would be numbing it daily to perform full mouth reconstructions. But to be honest, I didn't know in my clinical practice for 30 years at all about how important it was as a cue for swallowing. So the cranial nerve 5 motor root drives that jaw closing and opening behavior, and it's sending sensory branches from, not only the jaw, it's from coming from the teeth, the ligaments, like every tooth is in a ligament, from the mucosa, the gingival tissue, the buccal mucosa, and the tongue and the anterior tongue. So in another presentation, I can actually share with you how when you lose your teeth or you get dentures or you get dental implants, how that can actually affect your swallow. But here, I want you to focus on the chew cycle. Think of every time a patient chews or does one cycle, they're sending dense input to connecting neural fibers that influence the swallow. So basically, chewing, it's a rhythm. Breathing is a rhythm, chewing is a rhythm. And we know that they are connected to the central pattern generator of the swallow. But it's a primer. Think of it as like rhythmic activity that's juicing the network and keeping it in a state of excitability. So once that bolus is cohesive and lubricated, timing is cleaner and initiation is easier. So to recap, research really shows us 3 areas of influence for the oral sensory input. Timing is when the pharyngeal swallow is triggered. A stronger oral priming can reduce delay. If you have weak or poorly stimulated oral phases, you can leave the swallow underinformed, which may lead to increased residue and aspiration risk. From a safety perspective, the oral phase improves bolus cohesion and reduces premature spillage into the pharynx. It doesn't close the airway. That's not what I'm talking about, but it directly impacts how clean and contained the bolus is before the swallow is launched. From a force perspective, it's generating propulsion. Strong coordinated oral push is helping to move that bolus efficiently, and this is a neurosensory motor response. So here's the hypothesis I want to put on the table. When we reduce oral sensory input, whether from loss of dentition, pureed diets, or disuse, we are diminishing the signals that normally modulate the swallowing CPG. And we can blunt also that cortical activation in the brain. So basically, the oral phase doesn't just affect swallow safely, it can also reduce that anticipation and engagement that we talked about earlier. So now I'm going to focus on neuroplasticity and dysphagia. I recently listened to a presentation that was fantastic by someone named Dr. Catherine Arnold. She's a neurologist, and she described neuroplasticity and dysphagia and why it matters. She said that swallowing changes the way all motor systems do, right? It's the same. The change happens with use, specificity, repetition, and calibrated intensity. So in dysphagia, she was saying that means we avoid unnecessary NPO, we move patients towards the safest workable texture, and we prioritize task-specific practice over generic oral facial exercises. Today, we can further specify these principles to the subject matter at hand. For example, like we can say, use it and improve it could translate to skilled texture matching eating and swallowing as early as is reasonable. Specificity in our talk means oral phase work that actually resembles eating. Repetition and intensity means short, frequent bolus embedded in meals and therapy. So, frequent bouts embedded in meals and active and therapy. And intensity does matter with a goal of challenging the patient when possible. So if we map all these external inputs, you can see here Martin in 2009 and later updated by Jones in 2020. We can see the interventions that induce neuroplasticity. And so we can see them divided into non-behavioral and behavioral methods. And when we look at peripheral sensory stimulation, it's really interesting because we have electrical stimulation and non-electrical stimulation. And functional textures actually belong right here in the non-electoral sensory branch. So it's a structured way to increase the quality and quantity of oral afferent traffic during eating. And what I'm going to describe is functional textures using bite events, tongue palate pressure, and dissolution to drive information to that brainstem. And really, the goal here is not to replace, neuromuscular electrical stimulation or transcranial magnetic stimulation. It's basically adding repetition through a normal act of eating. So let's talk a bit about the chemosensory inputs, because I'm sure many of you know about chemosensory inputs like sour carbonation, temperature. And what we know is through multiple studies that these can sometimes facilitate or trigger a pharyngeal swallow by lowering the threshold and shortening latency, especially in impaired systems. So in practice, though, the effect is not guaranteed. More often, they prime the network, they can raise excitability in the brainstem and cortex, and they can increase the likelihood of timely initiation and improved timing coordination when a swallow is attempted. But the effect is dose and context dependent. So they talk about this idea of familiarity of flavor, the intensity, the novelty of the flavor, the bolus size. These can actually influence habituation, which can actually decrease their effect. So I'm going to talk to you about tactile, which is a functional texture is essentially food as a tactile stimuli. And how do they differentiate from food or liquids like carbonated liquids or oils like lemon oil as a chemesthetic factor? And so really think of it as chemesthetic cues versus tactile exercise. So when we think of sour carbonation, cold, capsaicin, these are brief surges that can facilitate or even trigger a swallow, but it's transient and there's a risk of habituation, like I said. But tactile chewing work is different. It's repetitive and keeps a brainstem loop warm and ready. Think of a match versus campfire. Chemesthetic is like the match. It's brief and it's sometimes a spark. Tactile practice, on the other hand, is like a campfire. It's like sustained fuel for timing. Like I said, like juicing up that brainstem activity around NTS and NA and the swallow central pattern generator. So what I want to share with you is there's been quite a bit of research on the tactile input, but they didn't have functional textures when they did these studies. But they did actually come to some interesting conclusion. And they said that texture and pressure cues are the brain's most reliable triggers for swallowing. So Steele and Miller showed that tactile pressure at the tongue-palate interface is the most consistent cue for initiating a swallow reflex. And that texture matters because it determines how much pressure the tongue has to generate. And this is more consistent for initiating the swallow reflex than taste or temperature. Now, Dodds found that purees often understimulate, leading to delayed onset and more residue. So the key point, tactile mechanosensory input is a stronger trigger for the swallow than taste and temperature. So with that, I want to talk next about functional textures. Now, I mentioned this several times, but I didn't define it for you. And so this is a new category of foods that do more than just passively meet safety standards. They're considered neuromuscular non-electrical stimulation in that neuroplasticity sense. So it's a way to deliver structured sensory motor work through eating high dissolving solids that rapidly form a cohesive bolus and align with the recommended ITSE level. So think of functional textures as giving you a food avenue to potentially rebuild and support your work through intentional oral phase activation. So basically, when we look at oral phase engagement and we can look at the solid dissolvable texture, we can say, well, what are the different things that it can be doing? And we can see that it's really broken down into motor involvement and sensory involvement. So if you take a look at what's happening with cranial nerve 7, if you have something that's solid and dissolving, you're inviting a bite. You're inviting the lips from coming around the product. You're inviting the cheek containment, all cranial nerve 7. When you present a patient a solid that they can pick up with their fingers, they are anticipating, remember the pre-oral phase, the mastication, they're anticipating salivation. And this elliptical chewing pattern is an initial pattern that develops, not because you need to chew, but because it's of the familiarity and the sensory stimuli that the patient is getting. You're also stimulating tongue movements, lateral tongue movements, tongue sweeping movements, and that reflexive swallowing and the brainstem stimulation that we talked about earlier. Not only that, but the tactile pressure from a functional food that's a solid dissolvable has different pressure on the palate than, say, a puree that thins when it enters the mouth. So we talked a little bit about the appetite and arousal, those limbic pathways. Again, having a solid sends a different message to the brain, a solid dissolvable. And also starting out like a solid foam and then dissolving increases taste intensity compared to a puree, which essentially volatilizes all of those aromatic compounds in the blenderization process in the kitchen. So I want to talk a little bit about that limbic system because when you're getting more tactile input, if you have a functional texture that is appropriate for level 4 and 5, so in IDSI language, puree level 4, mince moist 5, you're activating the prefrontal cortex involved in motivation and reward and emotional regulation. And the interesting thing is the shift in agency, right? It's really the narrative changes to from I can't to I'm doing it. So talking about basically engagement in the act of eating, but also in therapy. So we can look at these emotional influencers as real drivers for enhancing compliance, motivation, and clinical progress. So we know from several studies that puree diets can be safe from an airway standpoint, but they often fail to adequately stimulate the swallowing system. And this can lead to delayed initiation and residue. In fact, in a study that I'm going to share later, we see that there is actually more residue with puree than with functional textures. So if the sensory load or input can be raised with a functional texture and stay within the capacity for safety for a patient, we can improve the system from a neuroplasticity perspective and support that swallowing mechanism. So let's just talk about tube feeding because this is interesting because they are losing all of their oral sensory signals. And sometimes dietitians will report that the patients are feeling hungry even when they're receiving 100% of their caloric needs through a tube. And what I can share with you is that satiety isn't just about calories, it's about the oral brain feedback circuit. Without that cranial nerve activation from the oral phase, like you're not getting the taste, the texture, you're not then going to get the anticipation or the reward. So the brain is not getting a full message. It's getting a truncated message. It doesn't know fully that eating has happened. And that disconnect shows up as persistent hunger, disengagement from food, and even depression or social withdrawal. So I'm just going to take a little break to tell you a little bit about my sensory journey. I was recently on a trip in the most northwest tip of British Columbia in Canada in an archipelago called Haida Gwaii. And it's beautiful, but it rained for 10 days straight. I was on the open ocean for 10 days straight and it rained. But, this rain would come and you would get cloud, fog, whiteouts. It was like a total, hodgepodge of Pacific Northwest, skies and no sun. So we were in kayaks, and so when you're on the open ocean and you're on a kayak, you're gauging current, wind, and getting your visual bearings from seeing changes in the sky, reading cues in the water, and relying on seeing, when you're trying to cross a channel, you're looking at 2 points of reference on land. And you can hear the waves and you can tell the current, right? So it's really a lot of sensory information when you're on the water. But one day we had to go out at 4 in the morning to avoid a storm that was like 30 knot winds, and we needed to beat that storm. And what we experienced was a full whiteout on the open ocean. And basically, we could not see anything. And there was 9 foot waves. You can see here it's pretty flat and calm where I could actually take a picture. But when we hit those waves, it was complete whiteout. Our visual cues were gone. It was only auditory. You could only hear the waves, which told us where the land was. And that's, honestly, I just want to share that with you as the intensity, how much we rely on our senses. And food is a sensory input. And when it's gone, you might as well blindfold the mouth, right? You might as well remove that sensory input that is essentially intelligence. So now let's just talk about this intelligence from texture. It's really a message. So we've seen through this presentation that oral phase primes the swallow through continuous sensory input. The biting, the chewing, the tongue sweep, they all matter. And we talked about texture and puree versus functional textures. Now I'm going to review some recent literature on how functional textures that are aligned to IDSI level 4 puree can reduce residue and improve swallow efficiency. So now we have, through all of this background knowledge, a greater understanding why this might be the case through that signal quality from the mouth to the brain and the brainstem. So in this study that was published this year by Mochetti in Laryngoscope, it was done at Weill Cornell. And what she wanted to do is use fees to assess 3 textures. And they had blind raters. They had a functional texture, which was the Savory's crispy melt. They had puree, which was applesauce. And they used a Nabisco graham cracker to represent their regular solid. And what they did was they used vases, which I know James Curtis has talked at Tim's University about vases, and he's involved in this study as well. And so the swallowing safety and efficiency were measured using that tool. So the results showed that there was 219 swallowing trials, and a greater number of swallows was needed for puree versus the functional texture. There was also greater epiglottic and oropharyngeal residue with puree and regular solids versus the functional texture. And all 78 of the functional textures had a PAS of 1. And so they concluded that functional textures may be added to evaluations to a puree diet. Now, what I'm going to share with you is, yes, it says transitional here. And I said earlier that all functional textures are transitional solids. They have to pass the IDSI test for a transitional solid. So now, as a follow-up, Cleveland Clinic under Dr. Marty Brodsky, who I think also is presented to Tim's University, is going to look at what is actually happening to the bolus, how many masticatory strokes are used, the timing, the number of swallows, and what the tongue pressure response is to the sensory input. And they're going to be using the TIM software system in order to do that. The PI for that is Brian Hedman, who's the manager of the therapy department. So now I'm sure everyone, well, most people know about ITSE at this point, but just I want to just share with you, um, you know, the ITSE classification system. It's an international dysphagia diet standardization initiative. I volunteer actually with ITSE on education. It was created in 2015. It's a global framework and it promotes safety across settings. And they have a level from 0 to 7. Now, my area of expertise is obviously in the transitional foods category, and I'm going to talk a little bit more about this later. So, what I want to really get to is this point about sensory and safety, because these are two different points of food. And let's just break it down. So ITSE gives us a shared safety lens. It's using these great tests that are, you can do benchtop, that look at flow and fork tests and particle size and residue checks, right? You're using spoon tilt to look at essentially cohesiveness, and the fork pressure test, which is used for transitional solids. So basically, it standardizes what a product is at the point of service so teams can communicate and reduce risk. What it does not tell us is how that same food behaves on oral surfaces once it's in motion. That's tribology. Tribology is the physics of friction, lubrication, and adhesion during manipulation of a food. What happens in the mouth? There's friction, right? Like the food hits the mucosa, it hits the teeth, it hits the tongue. That's friction. There's lubrication, right? So, how does food behave when it touches saliva? And adhesion. So, this is during manipulation, bolus manipulation. So, is it possible that two ITSE level 4 items can pass ITSE test and still present very different mechanosensory fingerprints? So I'm going to share that with you. But here's my point. ITSE is necessary for safety and reproducibility. It is not a sensory framework. And we really need the sensory knowledge because sensory information is stimulatory information in the oral phase. And really, it sets in motion this relationship of the patient's reaction to the food. So, this is a really interesting concept. I want you to take a look at these three different products. One is applesauce, one is mashed potatoes on the right, and in the middle is a pudding. So, this is what I want us to rethink. They can all meet the ITSE level 4, right? They can all pass the spoon tilt test and hold in a mound. On paper, they're the same, but in the mouth, they're not the same. Applesauce behaves like a Newtonian fluid. It's slick, lubricated, it mixes quickly with saliva, it clears easily. Pudding is sheer thinning. It feels thick until the tongue presses, then it flows. So it requires effortful stripping against the palate. Now, mashed potatoes are sometimes pasty in quality. They don't move until enough pressure is applied, and then they can cling, leaving residue behind. So they can all have the same ITSE level, but very different sensory signals. And that means very different effects on swallow effort, bolus clearance, and residue risk. So what I want to share is that ITSE is a safety measure, but it doesn't guarantee how much sensory information the brain gets or how much effort the patient has to give. We don't have data on these variances within an ITSE level, but the sensory input may make a difference between efficient clearance and repeat attempts. So here's a nice way to look at it, right? When when we're looking at IDSI, we're looking at these properties, right? Density, hardness, cohesive, food residue, fragmentation. Those tests are actually measuring those qualities to see if they fit within the classification system or where they fit within it. Now, from sensory perspective, remember what I shared earlier about the different level fours. Slipperiness is something that is a sensory feedback. So, I've heard use of a dumbbell. Like imagine a 5 pound dumbbell, and you're trying to lift that up. You're trying to engage and make sure that you can do that. But what if that dumbbell is slippery? Does it change your grip? Does it change how easy it is to lose control? That's a sensory input. It's still 5 pounds, right? So this is an important attribute, which is tribology. The bite sound, you're getting sensory feedback there. Friction, lubrication. Is something feeling gummy at first, pasty, adhesive at first? As the oral behavior, the mouth moves it around. So can the mouth move it around? What are the qualities and abilities a patient brings to the table? Well, saliva is huge. The quantity and quality of saliva, their masticatory ability, the tongue strength. Basically, are they wearing their dentures? And what has happened to the tongue when the dentures are no longer being used? Um, this is something we look at in prosthodontics. The tongue movement, oral containment, and of course their dentition. So those are all patient-led variables. So when we look at the ITSE framework, I want to focus in on transitional foods because I find that this is a poorly understood category. It's most teams are focusing on the internal aspect of the pyramid in here, all of classifying all of these, because transitional foods is actually quite hard. Um, there's quite a lot of diversity, and so what it's defined as is foods that start as one texture but change into another with moisture or temperature change. There's no biting and minimal chewing is required, moderate tongue pressure only. So keep in mind this term, no biting or chewing is required. So it should dissolve or change shape without that force. There's no size restriction and degree of transition is variable, but must at minimum pass the work pressure test. So the crazy thing about it is there's foam type of transitional foods and there's gel types of transitional foods. Even ice is considered, according to ITSE, as a transitional solid. You can have magic cup, you can have ice creams. And so it is hard to kind of look at this group as a whole, and that's why functional textures kind of is parsed out but still fits within this definition. Um, so really what I understand is that the oral behavior plays a huge role in how transitional foods behave. If we think about the benchtop test or the fork pressure test, it's 1 cc of water for 1.5 by 1.5 centimeter cube of product for 1 minute. How many of you hold food in your mouth for 1 minute? How many of you have saliva that's the temperature of tap water? It's not really indicated if it's cold water, hot water in the IDSE test. The saliva has amylase. It has enzymes to break down food. It has a pH that's different than water. So there's a lot of differences that are happening in our mouth versus what is happening in benchtop, and really it bodes us to really test those transitional foods with a patient. I went ahead and did the first study on transitional foods with Dr. Schoon, Jason Ball, and Dr. Costi. And this was published in Dysphagia Journal. And what I wanted to do is test the behavior of transitional foods in the mouth. And it was the first study to really look at this. We wanted to look at, food in the mouth with no tongue pressure or moderate tongue pressure, but no chewing. And really looking at shorter times than the ITSE test. We wanted to look at 5 seconds and 12 seconds. And it was a spit test. So at the end, each participant would expectorate and we would do a fork pressure test to see if it would pass. So these are the products that were tested. One was a Savory's Crispy Melt, which was A. The Crispy Melt in dip was B. C was the shrimp chip. D was a baby mum mum. And E was something called the Eat Bar, which is a sweet meringue. And you can see at the bottom the demonstration of the fork pressure test. So the participants were 30 adults, 17 female. The mean age was 66.7 years, and it ranged from 50 to 88. 10 of the participants had dry mouth, and 8 had dysphagia. So we conducted a test looking at, was there a difference between these products and how they behaved? And it was a generalized linear mixed model to compare the dissolution rates via the fork pressure test. And significant differences in dissolution rates emerged for all pairwise contrasts except the Savory's Crisp versus the Savory's Crisp and Dip, and the shrimp chip versus the Eat Bar. So, but otherwise, there was quite a bit of difference between all of these transitional foods. And so then we looked at, at 5 seconds and 12 seconds with and without tongue pressure. So we were looking at these variables and trying to break it down and see how these different products behaved. And you can see that there was huge variance in the fork pressure test results at these shorter time periods in the mouth with and without tongue pressure. And so our conclusions were that there was statistically significant difference in rate of dissolve in the mouth between some, but not all transitional foods. And those crispy melts dissolved more consistently and faster than teething biscuit, shrimp chips, and the Eat Bar sweet meringue. And we concluded that you really need to assess specific transitional food on an individual basis due to these patient-specific oral conditions. And because these products vary so much in their dissolving characteristics. So back to the clinical reality you face. Safe, IDSI compliant trays that are still yielding low intake, low hydration, and low motivation. So the question now is, how do we use functional textures as a dosable oral stimulus to prime the swallow while you're actually feeding your patient? If the oral phase is underinformed, we know the pharynx is going to inherit that problem. So how can we give them more information according to a framework? And so I'm going to present to you a framework that gives you a way to increase that oral information during the first few minutes of a meal and in short bouts throughout the day and during therapy. So the framework is called EAT. Engage, activate, and train. So these are the 3 intentions of use of functional textures. Engage is about warming participation when goals are psychosocial, the pleasure, variety, texture adherence. All of you face this every day for your patients on puree and minced moist diets. And so if you can use a functional texture to activate, to basically engage this patient, you're going to improve satisfaction and patient outcomes. Now, activate is for patients at, when they have a nutrition or hydration risk. And as we saw, most patients with dysphagia have a higher risk of nutrition or nutritional loss or dehydration, especially when they're on thickened liquids or they are on more modified texture diets. So we use texture as a primer around meals. And what this does is it raises salivation, increases repeat swallows at the very beginning of the meal, and keeps attention on the task of eating. So this is basically getting the patient to focus on their meal, reduce plate waste, and increase this repetitive behavior of eating through a normalized process of a finger food to the mouth and initiating that bite response. Now, train is where we treat. We observe behavior on modified barium swallows. You can also observe it on fees and at bedside. You can teach specific oral phase skills, and when appropriate, you can actually bracket around something like vital stim, like neuromuscular electrical stimulation, with textures, using the functional texture before and using it after. So it's really about your intention. So if we look at engage, so again, when avoidance and apathy are a barrier, the first move is engagement. You give them agency. You're giving them sensory interest before a spoon arrives. They can touch, smell, and the first bite raises anticipation and perceived tastiness. So these are really interesting that when you eat with your fingers, the brain actually thinks it's tastier and more satisfying even before it reaches the mouth. We did a study actually on long-term care and using functional textures and redefining, and we did interviews, and across the board the residents were saying that, if you don't understand texture, you really don't understand eating. You don't understand the social aspects of food either. So in this lane of engage, we're not promising therapeutic change. We're restoring conditions under which patients would typically participate in eating. Think of this as occasional use on units, basically where monotony and that repetitive, same type of foods, same textures can really lead to low morale. And if your patients reach for it and they eat it, that's a doorway. So activation is again, here we're using, like, I'm going to go through timing. So you have your pre-meal timer. Okay, and a pre-meal primer, sorry. Think of this as you have functional textures and you're adding it at the very start of the meal, 3 to 5 bites, and when the tray arrives to stimulate that saliva and generate a couple of easy swallows. Now, the bag stays there, and during the meal, they're alternating bite and sip to maintain lubrication and pacing, or they're dipping pieces when oral dryness is high. And between meals, you can pair this with oral nutritional supplements. So the pattern feels natural. It's a bite, it's a sip, it's a swallow, rather than a patient having applesauce per se, which is wet, and an oral nutritional supplement. The pattern feels natural, and it doesn't feel forced. Um, so the point is doing this throughout the day. It's not like a single therapy block, but it's a continuous exposure to an oral exercise. And it's small, but it's frequent exposures that keep that oral brainstem loop warm while delivering calories and boosting hydration. So train is where we make the mechanism visible and we teach skills. On MBSS, I'm going to demonstrate what they're doing at Cleveland Clinic, which is adding a functional texture trial between puree and a regular solid. And they're observing behaviors of containment, tongue palate pressure, and timing. And basically, it's clarifying for them. It's helping them improve their diagnosis of whether it's the low efficiency of a swallow is sensory underload from puree, or is it pure weakness. And at bedside, you can use the same texture to elicit early chewing motions, increase tongue palate pressure, and practice propulsion in even in dining therapy. And so you can start to look at ways to measure success using these functional textures. And so I put here some potential areas of use and skills that you're working on developing. So, like I mentioned before, with neuromuscular electrical stimulation, you can place a texture before stimulation to prime attention and that get that brainstem loop started. Then you can use it again afterwards to consolidate newly recruited motor units with task specific chew and pressure, right? So let's look at what Cleveland Clinic is doing. They're starting to create a standard of use of functional textures in modified barium swallows. And, again, they're using the TIM software to help gain data. So they use the MBS-IMP routinely, and they look at the oral impairment component scores. And I don't know how many of you use the MBS-IMP by Bonnie Martin Harris, but basically, it's a really great tool for quantifying different areas of impairment. So, with a focus on the oral impairment, she has divided into lip closure, tongue control during bolus hold, bolus preparation, mastication, bolus transport, lingual motion, oral residue, and initiation of the pharyngeal swallow. So, now taking a modified approach to the modified barium swallow impairment protocol, we see here that the liquids is followed as routine. And the pudding is viewed, the barium pudding, in the lateral position. But then what they do is they coat one side of a savory's crisp with barium pudding and present it via a spoon. They instruct the patient to chew and to swallow as they normally would. Then the next solid is the Lorna Doone cookie. It's half a Lorna Doone cookie with barium pudding, and it's handed to the patient or given via a spoon if the patient is unable to feed themselves. And then you do the same instructions to take a bite of the coated part of the cookie and instruct them to chew and swallow as they normally would. Here is the setup for the protocol at Cleveland Clinic. And you can see here that there is barium here for demonstration, but you would only apply the barium just prior to PO presentation on the crispy melt because you don't want to early activate a softening of the crispy melt. So here is a patient that was seen at Cleveland Clinic. She had multifocal infarcts and infective endocarditis affecting her mitral valve. And what I wanted to show you here is, let me just go back for a second there. I started a little bit too quick. I really want you to focus. Here's the pudding going in. You can see there's no chewing behavior, but she did one clear swallow. Then with the transitional, which is the crispy melt, you can see the engagement of chewing. Now remember, this transitions to a puree consistency in the mouth, but you can see all of that great neural feedback going to the brain and the brain stem. Now comes the shortbread cookie. You can see here. Now also look, this person is missing all of their posterior molars. So that's why they're chewing up front. That makes chewing very challenging. And so they're using their tongue, pressing it up against the anterior palate where the rugae are, and you're getting some frictional effect there, but a lot of effort. Now we're seeing some particulation happening, fragmentation of the bolus, and then still trying really hard to get that effortful swallow and then coughing, right? So when we look at those three, so Brian was looking at those three different consistencies, and he was looking at oral transit time. Now, for the pudding, it was 2.4 seconds. For the functional texture, it was longer, right? There's more bolus manipulation, there's more preparation. It's 14 seconds. And with a solid cookie, as you could see, we could be heading into more fatigue, more difficulty. And then we look at the number of chews to first swallow. Well, there was no chews with the pudding. There was 12 chews with a functional texture. You could see that rhythmic pattern starting, and that's where we get into mastication rhythm. Was it a regular rhythmic pattern or was it interrupted? Was it irregular? Right? Think of breathing as a regular pattern that can be interrupted with apneic events. Well, chewing, you're getting signals from the texture itself. Now, bolus cohesion, was it cohesive or was it fragmenting? And the number of swallows required to clear that bolus. So another researcher, Bruno, has a manuscript out where she wanted to look at functional textures during therapy and as a daily solid supplement used on the tray, as we said before, to activate, right? To engage and activate the patient. So we have in a long-term acute care setting, she was exploring, this is an exploratory pilot study looking at crispy melts to support outcomes in diet progression. So her inclusion criteria were tracheostomy or post-tracheostomy, more medically compromised, they're very complex patients, NPO status or modified diet at admission, and they all had modified barium swallows. So she had four groups, right? Those that had the functional texture added to therapy, those that had it added to the meal tray daily, those that had it both in therapy and in the meal tray, and then no functional texture at all. And so here, what we see is that the mean age was 57.78. All patients in this study had both oral and pharyngeal impairments. They were medically complex, and adherence was high. It was at 86%, and there was no adverse events. So what she saw here was that when it was used in therapy only, they had diet progression that was more than not using it at all. But when they used it on the meal tray, it's that dose effect. It's just over and over again oral exercise, and you get a slight bump. But when you used it both in a guided fashion during therapy and you used it in nutrition, then you got the most IDSI level change. And she also measured the EAT score, showing big differences between not using the product as a functional texture and then use in different modalities. So essentially, my hope is that I've shared with you information from the lens of a prosthodontist and a food science lens as to how the oral phase is really valuable to you in swallowing. And we just don't want to get that white out for your patients, right? We want to give them more sensory input to essentially encourage sensory motor priming and encourage, the development of early chewing behaviors to maintain that juicing of the NTS, NA, and the central pattern generator. And so the other thing is I wanted to make sure that you recognize that foods within IDSI may differ, even though they're on the same level, they may differ in sensory input. It's really big for easy to chew regular, and we don't have time to go through all the different levels, but I really hope that you understand now how functional textures can be implemented according to the EAT principles. So I wanted to end and offer you guys a treat. So this is a QR code that goes to an order form. If you're interested in trialing functional textures in your facility, I would ask you to just take a picture of that and and fill out the form and tell in the form that you were at the Tim's course. The first 20 people that come, I will be making sure that you get a complimentary provider um, kit. It's an introductory kit and a guided sensory experience, not only for yourself, but for your team as well. So, this is my gift to you. So if you're interested, please go ahead and take down that code. Thank you, Brooke.
Some
I can end the show if you want and or stop the share.
Oh, sure. Reva, this was amazing. Thank you so much for your time and expertise. We do have some questions, so we'll go ahead and jump into Q&A. Um, the first question is in regards to when you were showing the examples from Cleveland Clinic Fluoro and talking about MBS-IMP. So this person said that they are located in BC, so it's possible that there are some differences in our barium products, which I do know for those in Canada, you all just got access to Veribar, so not sure if you're using Veribar or not. Okay, they go on to say our barium pudding is vanilla flavor, and we would be pairing it with savory flavored transitional food. Would that kind of sensory experience have some effect on the oral phase as well? I'm just wondering if someone dislikes the taste of something that we present, as often happens with barium products, how might that impact what we would see during the pharyngeal phase? I'm imagining increased hesitation, swallow delays, greater effort, etc.
Yeah, that's an interesting one. So yeah, if the Bracco product is available in Canada now, then great, because then it would follow the protocol and the viscosity of the pudding, etc. The adhesive quality of it onto a product is important. We have played around with powders and it does not work well. So with regards to flavor confusion and what is presented in the mouth, I think that it's really a good idea to kind of inform the patient before the product, because when they look at a pudding, they don't really know what it is, and if it does have a distinct flavor of vanilla or whatnot, then that could be helpful. Now, the only problem is if it truly doesn't taste vanilla and you tell them it's vanilla, then that can be flavor confusion. Um, but with regards to a sweet savory combination, to be honest, I am trained as a French culinary chef, and combining flavors, to be honest, can be a positive experience. So I would just look at, that perfect plate that we want to put in a restaurant. It would be to have, all different flavors presented on the plate to stimulate. So if we extrapolate that information to this application, I would say more sensory feedback is from more flavors. And so you might actually get what you were saying, but of course, we don't have any studies on that yet. It's a good question, though.
Awesome. This next question, I think you will really enjoy answering. Do you have any recommendations for patients who have reduced sensation, such as post-radiation and head and neck cancer?
Gee, Brooke, I think you should answer this one. Um, so I think that, you know, if they have reduced sensation, obviously this is a person-centered decision, so you would assess the products used with them, but it would, you know, one of the things I know about my product is that the urban spice has a lot more flavor to it. So, usually if they have reduced sensation, increasing intensivity of the flavor, as long as it's, not a flavor that would be noxious. I know with head and neck cancer, sometimes you have sensory stimuli that are not favorable. I would have to say that to be determined, we are going to be looking at those flavor profiles specifically for head and neck cancer patients. But what I do know is it's amazing to see with low sensation, low sensory feedback, hyposensory, that if you use the urban spice, they can taste it so much better than puree. You've got garlic, onion, parsley, figs, carrots, parsnips, toasted flavors, all of that in one, and it's the flavor explosion is happening in the mouth. So, like I was saying before with puree, it doesn't happen in the mouth. They get one uniform flavor. They don't get it's not a symphony. Like when we eat, it's a symphony. You get all these, think of drinking wine. You get the first flavor and you get the second flavor. And sometimes, if you're lucky, you get a third flavor. It's the same thing with solids.
Wow, I love your explanations. And I had forgotten that you were trained as a French culinary chef. Every time I talk to you, I'm just blown away by your dedication to this area of the field. So thank you. And for those who don't know, Reva's products have been used by thousands of people with head and neck cancer with a lot of success. I've had patients in my own practice that have used them and have really liked them. So if you haven't checked them out for that patient population, definitely do so. There's a couple more questions. Okay, so this person said, sorry, there's a lot of a lot of chatter going on. Here we go. Okay, this person said, if I don't have many transitional or functional textures at my facility, what diet could be best to maintain the CPG, avoid purees, and increase sensory input? It seems like I'm typically stuck with, I'm thinking she's saying soft and bite size, mince and moist. I agree that I do already try to minimize puree as much as possible. Any thoughts on that?
I don't really know. What's the question? Like she can't access functional textures, so what can be used but besides
Yeah.
a minced and moist and soft and bite-sized?
Yeah, she's saying what diet do you think would be best to maintain the CPG and avoid purees and increase sensory input if she's primarily at this point using soft and bite size and mince and moist. Do you have any ideas on diet?
Yeah, I mean, we're still following the ITSE hierarchy. Um, what I can share with you, honestly, there isn't an answer to that question that I can that seems like what I can tell you is that from a sensory perspective, minced and moist is not that different than puree. That's why when you advance your patients to a minced and moist diet, they'll be like, what the? They don't really feel the difference. And it's really about particle size in that case, right? It's really when you make that jump to soft and bite size that you get like the big change or sensory change. And that's why having these like these solid dissolvable textures can really help patients feel like they're winning. It's like, oh, I'm making progress. This is great. Um, so I honestly think that if you are looking at transitional solids, you might find some other transitional solids that you test and might be appropriate to diversify a more advanced diet level. I know at puree, crispy melts is the only one that is validated for puree diets. So I would say maybe at more advanced texture levels. You could use something else and just go ahead and do your IDSI testing and then do the sensory evaluation as well.
If someone's wanting to utilize Savory's products in their hospital, like let's say the person that just wrote in, it sounds like maybe they're in an acute care setting, how would they go about setting up that process?
Honestly, it would be just to fill out the form. The QR code is helpful. And then we basically get in touch with them. We work with teams all the time. We work with Encompass. We're partners with Encompass nationwide, and multiple acute care systems, hospital systems. So we're really well versed in how to work with dietitians and how to work with SLP teams, so therapy teams. And we actually love this because it's interdisciplinary conversation, and it builds connections. I mean, you probably are already having conversations around IDSI, but this is a new conversation that kind of solidifies those communications. And we help food service as well, and we help you with access to the products, which we have facility-based programs and access through distributors, etc.
I think a misconception I had when I originally came across your product several years ago was that thinking about using them on an individual basis versus actually using them as a therapeutic tool as you have, presented in this presentation. So thank you for that. So if anyone is on this webinar, and has had that misconception as I have had before, just know that a lot of teams are actually using this as an intervention, as Reva has talked about this evening, and it's obviously feasible to do in a protocol. So definitely think about that. We have a couple more questions. Let's see. This is specific about the product, so I'll ask you this one since we're on the topic. Are there smaller pack sizes available if we wanted to use a small quantity during an MBS or therapy?
So, again, go to the QR code and we can discuss a smaller pouch for MBSS and fees. Um, we can definitely do that for you. We also have pediatric, which we haven't talked about, but pediatric sizes, and that's more like the shapes and the size, but the full bag is oftentimes used in home health and mobile fees units if the patient is successful with it, which almost guaranteed if they're on a puree diet that they will be successful with this texture, then oftentimes the therapist just gives them the bag to continue with at home so that they have something to start. But in a clinical setting, say Cleveland Clinic, for example, they'll open the bag, they'll date the day that they opened it, and it's a resealable bag. So then basically they use what they need to, and then in 30 days, they dispose of the bag if they haven't completed use.
Awesome. I'm going to ask you one more question about this, and then we'll wrap up with a final question from an attendee. Would you be able to share just a short, like, synopsis about why you created this product? Because I know the backstory, but I'd love for you to share that with the wider audience because your passion and just dedication to this is really incredible.
Oh, thanks, Brooke. Um, well, I was born in India and my jaw was crushed at birth. And so I had multiple surgeries and treatment up to the age of 17. And during that process, I had a modified diet many, many times and also developed a passion for food. Um, I was surrounded by dentists my entire childhood because of that, surgeons, etc. And so that led me to go to dental school. And um, essentially, I went to French culinary school because of that too. And then it was my patients. So 30 years as a clinician, I was a researcher in implant dentistry, and I taught at Oregon Health and Science University for several years, and ran a course there. And it was patients that were struggling with dysphagia. And these are your head and neck cancer patients. They're the ones that end up in my chair. They need a full mouth reconstruction, balancing all the issues, xerostomia, many, many issues. And so I realized how bad it was for them. And we weren't taught about it. The idea of your discipline being so distant from mine, I just was like, this is crazy. And so I dedicated the past 10 years learning about dysphagia. and dysphagia science and meeting SLPs, going to all your conferences, learning, meeting researchers, and then developing a product that was a partnership with SLPs, RDs, MDs, food scientists, myself, and patients with dysphagia. And it took us 2 years to kind of come up with a prototype, which has now evolved. And to be honest, the one person that asked, we are developing stages of chew. So, the functional textures will grow, and as your patient rehabilitates, then you will have a new challenging texture to meet them. So that way, you're actually using food as nutrition and therapy throughout until they get to a regular solid. Or going down the ladder the other direction, neurodegenerative diseases, you can continually stimulate at their texture level using this kind of principle.
Amazing. Well, Reva, thank you so much for your time this evening and your dedication to this area of dysphagia and for partnering with speech pathologists. And to everyone who joined, thank you all for joining us this evening. I know we were talking about this in the chat, but if you missed it, if you're on mobile, just a quick reminder, if you would like ASHA CEUs for this presentation, just complete the brief survey within 7 business days, and then the replay for this event will be up on the TIMS website within 48 hours. And we will link to Dr. Barewal's website so you can check that out if you missed it. I'm seeing tons of positive responses in the chat. If you have any questions, feel free to reach out to us or to Dr. Barewal. And last thing, if you'd like a certificate of completion, just send us an email at tims-univ@tims.com. And with that, we will log off for the evening. Thank you all so much for being here. Bye, everybody.
You.